Courtney's getting me all set up here, but I will not be talking about analysis today. I'm giving you guys a little break on that. But we will be talking about something that is equally important, and that is mapping your locations appropriately for NHSN surveillance. And if you've been reporting device-associated infections and lab ID, you've probably already set up many locations. However, we do need to touch on a slight modification to our location definitions. So that's why we're here today. Now, for those of you in Atlanta, we will be going through what we're calling a decision tree for mapping locations. My colleagues and I get a lot of questions about how to correctly define a location. So we have this decision tree. It is in tab 4 of your smaller resource book. If you want to look at that along with the slides, again, we're basically reiterating everything that's in this decision tree in the slides, but if you'd rather see it all on a couple of pages, you can do that. For everybody who's listening or watching the web stream, we will be sending out an email in the next week or so that will have this document and some additional instructions for what we're talking about today. All right, so let's get started talking about locations. So for the next, 25 minutes or so, 20 minutes, we're going to review the importance of location mapping in NHSN. I'll define a few key terms used when mapping locations, and I'll also outline the steps for how you can define and map locations for NHSN surveillance. So we're not going to talk about how to add a location here. Here we're trying to look at, you have specific units in your hospital. How do you match the patients in that unit up with our CDC description? So our plan, and I'm going to copy what my colleagues did for their case studies and say that we are going to go through some straightforward and some complex examples, but what we can't discuss today as a group are some of the unique situations that each of you may have. We know that you all have unique units in your facilities that may not be easily defined by our CDC location descriptions. So instead of spending any time on some of those really unique situations, please send us an email to the NHSN mailbox. We may have some back and forth discussion with you. We may ask to talk to you on the phone about your locations, but we will help you with that process through the NHSN mailbox. Okay, so the documents that we're going to talk about, of course, the defining patient care locations in NHSN. I'll also make mention of our CDC location labels and location descriptions document. You don't have that in your packet today. You don't need it in your packet today, but that will be a document that you should have whenever you're trying to define your locations for NHSN surveillance. So let's talk about this importance of correct location mapping. Why do we need to go through this? Well, first of all, as you're probably very familiar now, is that NHSN location types have been developed in order to identify like populations within different facilities. So we're trying to categorize these patients and the incidence of HAI and other events in like patients. And with that, these like populations are believed to have similar risks of HAIs. They could have similar devices, similar invasive procedures, and they may have similar host factors. Also, again, as you're familiar with, many of our NHSN surveillance modules, especially for the patient safety component, utilize the location type as a risk factor. So, a couple days ago we talked about CLABSI and CAUTI and how those rates are all split by each individual location type. So that's why it's really important that we get the the locations mapped correctly. All right, we already talked about that we do pool the mean rates by location type. And if you incorrectly map a location, it can really affect the validity of not only your local data and comparisons to the national data, but also our national database. And if you're contributing to your state health department's data, it could impact their metrics and may require some additional validations on their part. That's why we're trying to take care of this up front. So the bottom line is, without correctly mapping your locations and units within your hospital, facilities are not able to compare your data to the NHSN data, and the NHSN data validity is then compromised for identifying trends in HAIs. So why now? Why are we so worried about teaching about this right now? Well, we're always concerned with making sure that you're aware of how to map locations. However, as Angela mentioned this morning, if you're participating in CMS's hospital IQR program and you have to report lab ID events, as we've been discussing this morning, you have to set up every single location, every single inpatient location in your hospital. And so this is for reporting beginning in January. So we're trying to encourage everybody and recommend that you start this process now. And so all of your locations will be set up so that when you have to start reporting those lab ID events, all of your locations are there for you at your disposal, and you don't have to worry about going back and trying to create and define these locations on the fly. So these are the three terms that we're going to focus on today. The NHSN 80% rule, which you're probably very familiar with. We're also going to talk about virtual locations and some special cases with mixed acuity units. The 80% rule, as you know, each patient care area in a facility that is monitored for NHSN is mapped to one or more CDC locations. And we'll get to that one or more part in a minute. The specific CDC location code is determined by the type of patients that are cared for in that area, and we recommend that you look at this over the last full year according to this rule, okay? So if you don't have a full year of data, let's say this is a new unit that opened up in your hospital, use the data that you have available to you in order to define this location. So all this to say that if you have 80% or more of patients that are of a certain type, then you would designate that area as that type of CDC location. So for example, if 80% or more of patients in an area are pediatric patients with orthopedic problems, the area would be mapped as an inpatient pediatric orthopedic ward. However, 100% of the patients in this unit would be included in your surveillance. Okay, so you want to make sure you count everybody in that pool as long as at least 80% meet that definition of that type. So now let's move on to virtual locations. This is something that we, and if any of you have contacted us with help with defining your locations, we may have actually instructed you or recommended the use of virtual locations. Virtual locations are used and created in NHSN when you're unable to meet an 80% rule for a location designation in a single physical unit, but you want to report your NHSN surveillance data for each of the major specific patient types in that unit, okay? So let's talk about this a little bit more. Here's an example that we threw together. So let's say you have 5 West ICU, and you have approximately 50% of the patients are neurology and 50% are neurosurgery patients. Well, neither of those obviously meets the 80% rule. So one option could be defining it as just a medical surgical critical care unit, because even though these are specialized neurology and neurosurgery patients, they are medical and surgical still. However, you want to keep those separate, let's say. You want to appropriately compare and risk adjust based on the specialties. So for this single physical unit, you would have 2 locations in NHSN for which you would report. So let's say, for example, we labeled these as 5 West N and mapped it to a neurologic critical care. And then we have 5 West NS, which we would map to a neurosurgical critical care. So in terms of surveillance, you would collect and enter the data for each of these NHSN virtual locations separately. So your neurology patients would be entered in one record, your neurosurgery patients would be entered on a different summary record. And you would obtain rates and standardized infection ratios for each location separately. So we would compare your neuro patients and your neuro data to the NHSN neuro pooled mean, and likewise for neurosurgery. However, this comes with a bit of a caveat. We understand it is not always possible to get to that level of granularity and operationalizing that type of surveillance and data collection. Oftentimes it could be easier when the physical unit is either geographically split by a patient service or those in which beds are designated by service. And that would make it a little bit easier to collect those data. We also want to mention that if you're using an electronic source for capturing these patient days and device days, talk to the software system, your IT department, your electronic health record system representatives, whoever is helping you collect those data, talk to them first to see if it would be possible to split out those data for you in this manner, okay? Because they may not be able to do that. All right, we're going to move on to mixed acuity unit. I don't have the full CDC definitions of mixed acuity unit in here. Those are in our locations chapter. But we do know that mixed acuity unit has been used by quite a few hospitals, especially with critical access hospitals. And these units are intended for your locations that are comprised of patients with varying levels of acuity. So you may have your critical care and step down patients in there. You could have ICU and ward patients in there. Maybe neither one of them meets an 80% rule. It's just mixed. So you could use a location designation as mixed acuity unit, but at this time, we don't have any plans to publish national pooled mean rates for this location type, and we wouldn't include it in NASIRs. And if you think of it, even at the local level, it's sometimes hard to assess what kinds of patients you have in here because they're all different acuity levels. You know, you may have, 50% critical care and 50% ward. You could have a mixture of all three types here. So when you roll that up to the national level and we look at mixed acuity, we really have no idea what types of patients and what level of care is required for those patients for those units. So we don't have plans to publish pooled means at this time. There could be implications on data reported for the CMS Hospital Inpatient Quality Reporting Program. Basically, mixed acuity units are not included in any ICU-specific reporting requirements. You may have ICU beds in mixed acuity. However, the location as a whole is not considered ICU. So if you have any ICU-specific reporting requirements for your state, for any other initiatives, and especially for CMS, those data would not be included. If you are concerned, if you go back and you look at your locations and you say, you know what, I mapped something as an ICU, it's no longer an ICU, it really meets a mixed acuity, I can't split the patients out, and it's your only ICU location, I recommend having a conversation with your QIO just to see how that would impact. There may be some additional steps or a waiver you may have to sign. CDC can't speak to that really, so if you are concerned with that, please have a discussion with them before you move forward. At CDC, we can help you find the best fit location, so that will be our job. So let's talk about steps for defining a CDC location real quick. And this is where we get into the decision tree. And we try to put this together based on the questions that we have received over the years and trying to help everybody define their unique locations. So there's really two major steps. One is to define the acuity level for the location. And then the second step is to define the type of service for the location. Looking at step one, the first question you want to ask yourself is this patient care area comprised of at least 80% of patients that are of the same acuity level? So that is, of course, critical care, ward. You may be looking at specialty care areas, which gets a little bit into the service type of the patient, step-down units. If yes, if you can answer this question as yes, you can move on to step 2 and map to a location type of that acuity level using our 80% rule for that type. And we'll spend a few minutes talking about that. Again, when we're looking at this mix of patients, when we're looking at the acuity level, look at the mix over the last full year if those data are available to you in order to determine the best fit. If no, let's say no, I don't have at least 80% of the patients that are of one acuity level, then the next thing you need to ask yourself is, can this patient care area be split into 2 or more locations in NHSN for the purposes of surveillance? So this is referred to as virtual locations, as we discussed. If you can split this up, you'll move on to step 2. If you're not able to split this location up for reporting, then you would map it to a CDC mixed acuity location, okay? And at that point, you'd be done defining that individual unit. Here's just a snapshot of that step 1 decision tree that will kind of guide you towards where you need to go. And so we'll just go ahead and move on. So step 2 is where it can get a little long and a little complex, and you may find yourself in situations where you're having trouble making your way through this based on your specific unique situation. So, certainly we can answer those questions through the mailbox, but hopefully this will help most of you. So step 2, the first question you ask in step 2 is this patient care area a general medical, surgical, or medical surgical unit? Or is it comprised of patients from a specific service type, such as burn patients, cardiothoracic patients, trauma patients? And I have a link here, or a URL at the bottom for our locations document. So it's in our patient safety manual. So please, when you get back and have to define your locations, have that handy. If you think that this unit is comprised of general type of patients, such as general medical, general surgical, then you need to ask yourself, are more than 60% of patients either medical or surgical? And in a second, we'll talk about why we're saying 60, because you're probably expecting it to be 80%. And this 60% is kind of the new little clarification that we've provided in our rule in order to make these locations easier to fit into our descriptions here. So if you could say that yes, at least 60% of the patients are either general medical or general surgical, you would create a location in NHSN that is mapped to that majority type, medical or surgical. However, if it does not meet that 60% medical or surgical, then you would consider it a combined medical surgical location. Now, in the past, we've always had this 80% rule and then define it as medical surgical if it's approximately 50-50. Well, there's a gap there. So this is how we fill the gap. So if you're not at least 60% general medical or surgical, then you can define it as a medical surgical ICU. So your mix of patients should be 50-50 to 60-40 mix. And here's just a snapshot. And looking at the left side, that's what we just covered today. And at that point, you would be done. You have either general medical, general surgical, or medical surgical. So now let's get into the specific service type of patients quickly. So if you have a specific type, let's say you have burn or trauma, you want to use this 80% rule. Does this unit meet the NHSN 80% rule for locations? Obviously, if yes, you create a location in NHSN mapped to that type, then you're done, right? That's the best case scenario. But if no, we start to repeat the steps and the decisions that we made for our other location types. You're going to ask yourself, can we split this into 2 or more units in NHSN for surveillance and use the virtual location? Okay? And this is just so that you can be sure that if you want your burn patients to be compared to burn patients in the national data, you would pull those burn patients out and report them separately from everybody else in that location. So if you can create virtual locations, then you would create those locations based on the specific service type. And if not, then you go and look at general, medical, surgical, or med-surg, just like we followed with the first part of step 2, okay? So there's a little bit of going back and forth on that decision tree, but this is all trying to guide you to what we feel could be the best fit CDC location for your scenario. So what I want to do is I'm going to kind of skip through this because we talked about medical, surgical, and I want to talk about, oh, actually, before we go on, I'm going to go through a couple of examples that we have. But we recommend that you reassess location designations and the description whenever there is a major change in patient types admitted to a location or new locations are added to your hospital. So, you know, we get this question a lot, how often do you want us to look at this? Well, when you know that there is a change in your organization or a change in the types of patients going to that unit, that's when we would like you to reassess. So let's go through a couple of examples. These are also in your decision tree document. But let's say you have an ICU. You've already determined that this is an ICU location. It meets that 80% acuity level rule. And you have 40% neurosurgical, 40% surgical, and 20% medical. And that is quite a mix. So what do you do with that? Well, what we've said, what we've determined is that you've got a couple of options. First, you can define it as a single CDC location, which is surgical critical care. Why do we say that? Well, we already know it meets the 80% rule for critical care, but it does not meet the 80% rule for a specific service level alone. But when we combine all of the surgical patients, that total does equal 80%. Okay? When we combine neurosurgical with the general surgical. Your second option is to use the virtual locations. You have neurosurgical critical care and surgical critical care. And we would say that, so you have one that meets the 80% rule for neurosurg, and the other would meet a 60% rule as a general surgical service when you combine the surgical and the medical patients. Okay? So that's how that works out. Second example is that you have a unit that is comprised of 60% medical ICU and 40% step-down patients. The first option, of course, is to do a mixed acuity unit. That is one option. However, if you'd prefer to stay away from mixed acuity unit designations, and I'm sorry, the reasoning for that is because it's not comprised of at least 80% of patients in the same acuity level, okay? But again, this is not considered an ICU location for the purposes of surveillance, so it would not be included in any ICU-specific reporting requirements or measures. So your other option would be to map it as two virtual locations. You have your medical critical care and your step-down unit. So you would split out those locations, you would have your acuity levels appropriate, and you could report the data in that manner. So that concludes our talk about locations. I went through that pretty fast, but of course, you know, start to use this decision tree, and if you're having trouble or you have a really unique situation, please contact us. And you know, sometimes we have to confer with each other on the correct answer. So, question?
Yeah, Maggie, when you change locations, how does that impact the data analysis piece?
Okay.
What are your recommendations to IPs around running reports?
Okay, so that's a great question. Thank you, Joan. So the question, so how will changing your CDC locations impact your rates and your comparisons? Well, if you decide, let's say, okay, you know what, this is not a, you know, this doesn't meet this specific site, let's say a neurosurg, we just need to call it a surgical ICU, you would create a new location in NHSN, and The new location and the reporting for that new designation would not be linked with the old one, okay? That would keep them separate and compared appropriately to the national data. And when we provide guidance and put this decision tree out, we'll have some additional guidance on what to do in that kind of scenario and what the impact will be. Yes, Mary?
Just a question about operationalizing the virtual locations. Let's say, for example, that I'm critical access hospital and I have a floor with 20 patients on it, and so I'm splitting this up into step down and med surge.
Okay.
So I have to assign a number of beds to each one of these virtual locations.
Yeah.
So I'm going to estimate based on what my numbers look like.
Sure.
But suppose on a given day I have more central line days than I have patient beds.
Then you have patient beds. That's a great question, and that's I think that is okay. I think if you were to run into that scenario, I guess you could set up, looking at Teresa, because I know we've talked about this. I'm trying to refresh my memory, because I don't know if you want to split in half based on the estimates or if you want to put the full bed size in. Given that, you know, we haven't analyzed too much on the comparison of patient days to bed size because we know it can change. But we know that states have looked at that specifically. So that's a great question. We can include that in our guidance and make sure to note that how you would assign the bed size. So thank you for that.
You bet.
Right. Well, thank you all. And that's it for me. I am done.